So when it comes to identifying challenges in the diagnosis of MDS, of course, the way we diagnose the disease is by taking a bone marrow biopsy and evaluating this biopsy under the microscope. So in order for us to diagnose the disease per WHO criteria, the 2016 criteria, the hematopathologist needs to identify at least 10% or more of any cells in any lineage, in one lineage or more, that have dysplasia, where the cells looks funny. That's by criteria. Or in the absence of dysplasia, the pathologist, we can identify presumed diagnosis of MDS in the presence of some cytogenetic abnormalities, such as abnormalities in chromosome 5, 7, and others, as defined by WHO criteria. And the last thing, the pathologist could also identify myelodysplastic syndromes with increased blast. The blast percentage will be above 5%, but less than 20%. So the challenge in the diagnosis become when the patient have less than 5% blast, when they don't have any cytogenetic abnormalities, and they have normal karyotype, of course, and then the dysplasia either absent or not enough to call it MDS. Because also identifying dysplasia required very experienced hematopathologists that look regularly at the slide. And many studies have shown actually there are discordance between what hematopathologists consider dysplastic versus non-dysplastic. The other challenge today that we have with the diagnosis of this disease is the introduction of several new terminologies that we start using. These terminology range from clonal hematopoiesis of indeterminate potential. With this, when the patient have normal, absolutely normal blood counts, but then by doing next generation targeted deep sequencing, we identify a mutation on that panel. Of course, with those individuals, there is a risk of increased risk of developing hematologic malignancies or other type of malignancies in the future. There's also another terminology called idiopathic cytopenia of unknown significance, or ICUS. And in this, where we do a bone marrow biopsy, we can, the patients present with cytopenias, but the pathologist cannot identify dysplasia in the bone marrow, and we do next generation targeted deep sequencing, and we cannot identify any mutation. There's a risk of those patients, of course, to progress to full-blown myelodysplastic syndromes. The other new terminology that we have, which sometimes make it difficult to distinguish from MDS, is clonal cytopenia of unknown potential. And with this, where the patient present with pancytopenia, their bone marrow either don't have enough dysplasia or no dysplasia at all to call it myelodysplastic syndrome. The blast percentage is less than 5%. The cytogenetics are normal karyotype, but we identify typically around 1 or 2 mutations with very low valid allelic frequency on the next generation targeted sequencing. Those patients, they behave some extent to similar to like lower risk myelodysplastic syndromes patients, and some of them will also develop myelodysplastic syndromes in the future. So I think these are the challenges. One, in the identifying morphologically whether the patients have MDS or not, and then trying to distinguish the disease from the other terminologies that now available that look exactly like MDS, but by the definition of the WHO criteria cannot be described or confirmed as myelodysplastic syndromes.